it's a respiratory disease. That is what people were thinking. But now everybody knew that it's also a part of the disease. So similarly, we are learning every day about the disease. This is no more a respiratory disease. It involves every system in our body. And each day we are learning new things. And therefore, what is the strongest weapon to fight this disease? The strongest weapon to this disease is knowledge. And as we accumulate our knowledge, and each day we are updated, we can fight this disease. So neurological manifestation, if you go through Lancet, it says that so many situations, stroke is one of the manifestations. We lost our former president and he had stroke and he had COVID. We don't know whether COVID caused stroke or he had stroke and went to a hospital, got COVID, we don't know. But so these are all the new knowledge which is coming up, and we should know what is happening to our patients. We should know how to tackle these situations. And another most important thing is documentation of all these things and then conducting research. So this is for posterity. Not only for posterity, it is for current time also, because many things which we are learning from what is reported in Lancet, what is reported in BMJ, whether that is relevant in India, we don't know. We are just copying it and we are saying that this is relevant. And we thought of conducting a lot of research in Kerala, but there were a lot of oppositions, hitches. Now we are realizing that the COVID cases are there in every hospital, and every doctor must be able to document what they are seeing, how they have saved this patient, how they lost the patient. All these documentation has to be there, and then it will be a great asset. And university is really interested in supporting each and everyone who is ready to conduct such research, and this is for our future. Maybe after 10-15 years later, people will ask what the doctors in Kerala did at that time. There should be document. We have fought the disease in such a brilliant way, and we are reducing the mortality, but there must be document. Nipah came, and probably the best way Nipah was dealt in the world is by the Kerala doctors. But do you have any documents? Is there any real documentation how you fought Nipah? I'm very sorry to say that we have not made any documents. That should not happen. So, and here the university is ready to help each and every one of our faculty who is ready to research in whichever way you need support. We have centers, and we will definitely support. With these few words, I declare that this session inaugurated, and I welcome once again our learned faculty and also the delegates who are attending this webinar. Thank you so much.
Thank you, sir, very much for your inspiring words. And I invite our Honorable PVC, Dr. C.P. Bijayan, to just say 2 words. Sir, you are muted. Kindly unmute, sir. Sir, you are muted. Please unmute yourself. Vijay sir, on unmute ചെയ്യുമോ?
താഴെ ലെഫ്റ്റ് സൈഡ്, താഴെ ഇടതുവശത്ത്.
Sir, Vijayan sir, the connectivity issue, sir.
Okay. Now Vijayan has come back.
Sound in the problem.
I think we lost connection.
Okay. Sir,
No. Now he's not seen at all.
Yeah. Sir, please, sir.
Okay, now Dr. IP is actually the coordinator of this and today's moderator also. Dr. IP, you want to say something?
Yeah. Honorable Vice Chancellor Mohan sir, Pro Vice Chancellor Vijayan, Raj Mohan sir, Registrar Dr. Manoj, other faculty members, Dr. James Jose, Dr. Shaji CV, and other members. It is my proud privilege to be part of the pet project of our Honorable Vice Chancellor of Kerala University of Health Sciences. He has been, we have at the apex of the university a person with rich experience in leadership. I thank him for implementing this topic as a webinar, a series of webinars for super speciality. I have to thank Rajmohan sir, who silently master planned the COVID series on behalf of the Vice Chancellor. He's a person who goes into the details. And I think it is only appropriate to discuss COVID pandemic at this moment. It affects different specialities and has research implications, as Vice Chancellor has already pointed out. We have all the super specialties represented in this series. We have stalwarts in the field. They will be covering most of the aspects about their specialities. I wish all the best for this series. I thank the Vice Chancellor, Rajmohan sir, for giving me this opportunity to organize all the people together. That is all. Thank you very much.
Thank you, Dr. Aip. Now, Dr. C.P. Vijayan, our Honorable BVC has come back. Vijayan sir, unmute.
Yes, unmuted. It was a connectivity issue. Respected Vice Chancellor, Mohan and Kundumal sir, Rajmohan sir, Dr. Thomas Aip, Dr. James Yos, Dr. Jayakumar, Dr. Suma. I'm seeing a lot of familiar faces, Dr. Shaji. Yes. As mentioned by our Vice Chancellor and also by Dr. Thomas Aip, we are in the learning curve as far as the COVID-19 is concerned. All of us thought that it was a respiratory disease, then later a diarrheal disease, then a neurological problem, then cardiological. So now we know that it affects all the systems, and we have to learn more and more. And as day goes, we are learning a lot of new information from the patients and also by the administrators, also by the from the health workers. We are learning. So, as mentioned earlier, university is planning to do extensive research in the state of Kerala, so that we will be able to publish a lot of information which is useful to the rest of the world. So this is a series of webinars organized by our Rajmohan sir, and also led by the super specialty heads of departments of the government medical college, of the medical colleges of Kerala. It will be most useful to the rest of the world. So I am
Again, some connectivity problem is there.
Sir, poyeno.
Saravilla. Suma is there? Suma, your remarks about the previous seminar, because you have organized all those things, our 5 sessions, it went on very well. And the feedback is very, very inspiring. Everybody said it was very useful. And your remarks, Madam Suma.
Okay. Honorable Vice Chancellor and all the dignitaries, we had a series of sessions on basic clinical sciences about the COVID-19, starting from the clinical features, laboratory diagnosis, and management, the critical care management and all that. And as Dr. Rajmohan said, this was a very interesting session because all the faculties from various disciplines, they have raised a lot of questions and there were good discussions also. So that is there. We have kept it a basic level. The whatever should be known about the COVID has already been said, and now we have to know more about the other systems involvement, because this is the stage when we started in. The second patient was at Alleppey, that was on January 30th, and from there we have seen almost now around 800 plus patients, and now the scenario is changing. Previously, we used to have a symptomatic patient, but now we have patients with the multiple comorbidities, patient with hypertension, stroke, diabetes mellitus, and all that. So this knowledge, this series of webinar will be very useful for the management as well as to look at the patients and come out with whatever is needed. So like the previous one, this would be equally needed one, and it will be good, and wish all the success for this series of seminars. Thank you. Webinars. Thank you.
Thank you, Dr. Suma. I place on record the presence of other dignitaries like deans. Dr. Shankar is there. Shankar sir is there. And a very senior faculty like Dr. Gobinathan Nair from Karakonam. I place on record all the presence with gratitude and regards. And now I request our registrar to say the vote of thanks for the inaugural session, and thereafter we will go to the business, and Dr. Aip will lead us.
Okay, sir. Thank you. Honorable Vice Chancellor, Professor Dr. Mohan sir, other dignitaries. At the outset, I feel this is a very glorious webinar when compared to other webinars, simply because the presence of very senior, very busy clinicians, academicians are gathered together. So it gives a feel that something is going to happen in research in the field of COVID. So thank you so much joining with us. And on behalf of the Honorable Vice Chancellor, let me extend my sincere gratitude for joining with us and wish you all a very wonderful 5 evenings ahead. Thank you. Thank you. Okay, sir. Over to you, sir.
Okay. Thank you very much. And I again repeat, kindly mute, and those who want to raise questions, please use the chat box, and the discussions will be answering to all the questions. Please use the same link on all days. You are free to please feel free to ask your doubts using the chat box. Thank you very much. Now over to Dr. Aip, who is the moderator of today's session.
Good evening. With the permission of the Vice Chancellor, let me welcome all the delegates to this 5-day series for COVID and super specialty specialities. So first speaker of this series will be Dr. James Jose, who is professor and head of the Department of Neurology at Calicut Medical College. He is my friend. He's a gold medalist in our batch. I think he is the best person to start the series, and I wish I give the mic to him. Over to you. Can you share your screen? Share screen.
Good evening, everybody. First of all, I think our Honorable Vice Chancellor and other respected faculties are observing this webinar. So I thank all of them, and I appreciate the Health University's effort for conducting this program and giving me an opportunity. Actually, every day we are hearing about COVID, and frankly, I shall tell you, when this topic was prepared, then only I understood how the disease is causing problems in different organs, especially in neurology. So this was an opportunity for me to learn about COVID, which will be very useful for the further research as well as the patient management. Often we are called from the ICUs saying that one patient is having one problem, neurological problem, he has altered sensorium, or he has hemiplegia and all. And I think that most of the super specialists won't have much knowledge about the involvement of the systems by the COVID. And I appreciate that the university has arranged such a program for the super specialty field. And again, I thank everybody for giving me this opportunity. Now, this is known to everybody. If anything kills over 100 million people in the next few decades, it is likely to be a highly infectious virus rather than a war. And I know that these words of Bill Gates is known to most of the people. And now we are having the prediction is now become correct. You know that it's called corona because of the crown. The word corona means crown, and the name corona is taken resemblance because the virus resemblance to the solar corona, which is seen during solar eclipse. Know that this talk is divided into two parts. First part I will be handling. The second part is handled by Shaji. I will be handling mainly regarding the virus and its pathogenesis, because even though it is known to all the basic science people and other specialists, it is not very known to the neurologist. Shaji will be elaborating the neurological manifestations. So let us see what is happening. So many questions are coming. How is the origin of the virus? When the corona will end? What is the treatment? When will be the vaccine available? Lot of questions are going on with no answer. It's as if the blind people seeing the elephant and predicting. Some people say that it's a creation of China. Some people say that it is an incarnation to destroy the human ahankaram. Some people say that it will end soon. Some people say that it will last for 2 or 3 years. People are advising that you have to live with the corona. You have to learn corona. So much confusions are there still. But we know something. This is the one. As Mohan has said the first corona was reported in January in India, and we are sure about one thing, that is coronavirus affected the total population of the world. Even though we are not affected with the disease, it affected all the people. It changed the plans, the lifestyle, and thinking of people. And I used to say that we are all affected by corona, even though we are not infected by corona. So such a big problem we are facing, and you have seen that by March, August 31st, about 25 million people are affected in all over the world, with death more than 8.5 lakhs, and India more than 3.7 million, with the death rate approximately 60,000. Now, we should know something about the virus. We have seen this one, I have seen these spikes, but was not aware this is like that. Like my microbiology professor, Thomas Ives' father, used to teach us the virus particle which has got the protein and the nucleocapsid. It is also like that. Coronavirus is also like that. It has a covering as well as an RNA. Three covering proteins are of importance. The most important one is the spike protein, which is called S. Then another protein called membrane protein, and then there is an envelope protein. Spike protein is the one which gives the appearance of a corona or a cow to the virus. And inside the cell, inside it covering, there is a viral RNA. Now, if you see the spike glycoprotein, this is the structure, ultrastructure of the spike glycoprotein. This protein is very important because this is the protein responsible for the virus to get attached to the cells by its binding site. So this is the protein, spike protein, otherwise called S protein. This spike protein has two components. The first is S1, the second is S2. The S1 is the one which is responsible for the first stage of viral entry. It contains the receptor binding site. This is the receptor binding site. The S2, which is responsible for the second stage, that is fusion of the cell, host cell and virus. So these two functions are carried out by the glycoprotein. And you can see that there are several receptors and cells, cell markers. These are the receptors and membrane proteins which are involved in viral entry into the cell and helping the viral multiplication. We'll see what are they. So two membrane proteins are there. One is called ACE2, which is called angiotensin converting enzyme 2. The second is what is called CD147. These are the two membrane proteins to which the virus attached to a cell. This predominantly, it's the AC2 which is responsible for the viral attachment or the receptor, and this CD147 is considered as an alternate path. Then there are two other proteins which is called transmembrane protease serine. It is always called TMPRSS2, and another protein which is called furin. These two proteins are the one which helps the virus to get fused with the host cell. These are the two receptors, and these are the two ones which help the virus to fuse with the cells. These receptors are all important. not only in the pathogenesis, but also for the development of chemotherapies. It's very beautiful if you can block this attachment by somehow either destroying the viral glycoprotein or by altering the structure of AC inhibitor, then it is easy to destroy or easy to treat COVID. The same way, CD147, if you somehow down-regulate this one, the entry of the virus may be abnormal or may be prevented. Nowadays, we have one drug which is, that azithromycin is used in COVID, and the site of action is considered to be CD147, which down-regulate the gene of CD147 so that the viral attachment is decreased. So these are the potentials. So you all should know the importance. And incidentally, one thing, this molecule is having a lot of research previously also by the Prostatic Foundation, because it is related to a gene which is related to its gene is related to prostatic cancer and androgen. So that research is now going to be very helpful for us. Now you see what happens. This ACE2 as angiotensin converting enzyme 2, it is seen in so many cells. The common sites are these. One is type 2 pneumocytes of lung. Second is enterocytes in the gastrointestinal tract. Third is endothelial cells of the blood vessel and in brain. And you can see that in brain, cerebral cortex is involved. Cerebral cortex, striatum, hypothalamus, and brainstem. These are the sites where you see a lot of AC receptors. Some of the manifestations, you may be surprised. During the initial stages of COVID, we had a patient who was diabetes insipidus. I think it was in April or so. And we were not aware that hypothalamus has got this receptor in plenty, and that is why he developed diabetes insipidus. So any of these structures can be involved directly by the virus because of these receptors. Now, because of its wide distribution of ACE2, the viral illness, COVID, become a multi-system disease. Most of the viral illness are not a multi-system one. They are all affect only one organ. For example, influenza, it may affect the lungs. Herpes simplex will affect brain. Japanese bee will affect brain, like that. But if you see COVID, directly or indirectly, it affects all the systems: neurological, renal, hepatic, gastrointestinal, thromboembolic complications, cardiac, endocrine, and dermatological. Just like a systemic illness, it becomes a systemic illness. That is the sad aspect and the fearful aspect of COVID. Multi-system involvement. If it would have been a viral pneumonia, it would have been easier, or it's encephalitis, it would have been easier. Most of the patients die because of the multi-system involvement. Now, there is neurotropism of COVID-19. That's a peculiarity. If you compare other COVID viruses, this COVID-19 has, that is SARS virus 2, coronavirus 2 has more affinity for CNS. This is because ACE2 is extensively present in neurons and endothelial cells. And the second factor is CD147 is also widely expressed on hematopoietic cells and neuronal cells. These two factors make this virus a favorable site for the central nervous system. You know that it's estimated that up to 80% of the people is having anosmia as the initial manifestation. And it is now considered that anosmia is due to the direct spread of the virus through the olfactory nerve to the rectus gyrus and olfactory centers in the brain. and virus was isolated from there. This is because of this abundance of the organism, abundance of these receptors there. Now, this factor is known to everybody. COVID-19 affects more men than women, more men than women, and men with COVID-19 are 3 times more at risk of worse neurological outcome and death. So be very careful with the male people. This is because there is increased expression of this ACE2 in male, and there is upregulation of the TMPRS2 by androgen. This upregulation of the androgen was the point of research for the prostatic cancer, and it is considered that their research may be going to be useful for the development of the chemotherapy against this virus. Now, knowing these factors about the virus, know that women and children are relatively protected. Should remember that they are being relatively protected, but the disease is more severe in children also. They are protected because reduced expression of these 2 markers. They are better innate immunity and environmental less outdoor activities and smoking. This will make the women and children a less potential candidates for a CNS involvement and viral infection. Now, I shall go to the pathogenesis of the neurological and other COVID manifestations. Know that the first pathogenic mechanism is, I told you that the virus get attached to the angiotensin converting. When I see this one, I automatically say acetylcholine, because we are more accustomed to acetylcholine. That's why the short form is usually considered as acetylcholine. No, it's ACE2. It's attached to the virus, and there is a down regulation of this angiotensin converting enzyme 2. This is a down regulation. Now we will see what is the role of this ACE2 and its down regulation. This is taught in a first year MBBS, but we all forget after the MBBS, isn't it? Renin angiotensin. Know that angiotensinogen is there, which is converted by the renin to angiotensin 1. And angiotensin 1 is converted to angiotensin 2 by the angiotensin converting enzyme. This is renin angiotensin pathway. This is a strict, strong vasoconstrictor. And this axis helps us to maintain the BP when there is a BP fall or hypovolemia. Now, this part is not emphasized in physiology, the metabolism of angiotensin 2. But in the case of COVID, that becomes very important. We all study that angiotensin 2 is being metabolized by the lungs pneumocytes, and the enzyme is ACE2. It converts angiotensin 2 into angiotensin. This one is a vasoconstrictor. Angiotensin is actually a vasodilator, not constrictor. This is a constrictor, this is a dilator. This pathway is blocked when there is a down regulation of its gene and the receptor. The result is there is a vasoconstriction because of the accumulation of angiotensin 2. There is a vascular permeability alteration. These 2 affects the CNS very badly, not only the CNS, but also the other systems badly. Vasoconstriction is always problematic for brain. And increased vascular permeability is equivalent to destroying the blood-brain barrier. So this is the first pathogenic mechanism. The second pathogenic mechanism is what is called endothelial inflammation. Know that COVID virus, they have got the inhibitor. These endothelial cells are rich in this ACE2. Naturally, there will be attachment of virus to endothelial cells with the inflammation of the endothelium. This endothelial inflammation will result in two problems. One is there is increased thrombin production and decreased fibrinolytic activity. The result, you know, that increased tendency for thrombus formation, stroke, and other things, pulmonary embolism. And sometimes if this is going on, patient will develop DIC. And another problem at this stage is there is sometimes the same problem can lead to vascular inflammation, endothelial inflammation, and sometimes vascular wall inflammation, which may result in vasculitis. You know that COVID is well known to produce Kawasaki-like syndrome, which indirectly affects the CNS. These are all due to the endothelial or vascular wall inflammation. The third mechanism is dysregulated immune response. What is otherwise called cytokine release syndrome or the cytokine storm. The main target for cytokine release syndrome is lungs, but CNS can also be affected by these immune mechanisms and its aftermath. And lastly, you know that there is direct cytotoxic effect for the COVID-2 virus. Virus enter the cell, fuse with the cells, lyse the cells, and destroy the cells. Billions of virus may enter the cells and cells may be destroyed. This will affect the CNS like any other site. For example, encephalitis, myelitis, meningitis. These are all caused by the direct cytotoxic effect of the virus. And it is considered that anosmia is also a manifestation of direct viral entry into the CNS. It was demonstrated that the olfactory epithelium is actually a part of central nervous system. Unipolar neurons are there. Actually, epithelium contains neurons. Unlike the other sides, the peculiarity of the olfactory epithelium is that unipolar, the receptor itself is a neuron. And the central processes are going to the olfactory bulb and all. So the involvement of the olfactory epithelium is actually a direct CNS involvement. And subsequently, the virus gained entry into the CNS and probably the portal of entry as respected, I think it's the Vice Chancellor has mentioned that it is the direct viral entry to the CNS is through that tract. It's very likely. So by these various mechanisms, the CNS is involved. And I will enumerate the CNS involvement and then hand over the session to Shaji. So these are the CNS manifestations. I will enumerate that. See, COVID-19, I told that it has got a lot of systemic manifestations. These systemic manifestations will result in coagulopathy. The result will be stroke and hemorrhage. Definitely, stroke is a manifestation. I know that whoever is treating COVID is seeing a lot of stroke in them. As we have all seen, our former president has a stroke. And we had experience of young people coming with stroke. And COVID manifestation, the first manifestation we have encountered, stroke as the first manifestation. And hemorrhage is another problem. Really, we had a patient in the initial stage who had COVID and patient went into coma. We are totally in blindness why he was in a coma for after recovering from the lung problem. Out of the ventilator, he becomes utterly comatose. And the MRI and CT scan showed that he has extensive subarachnoid and intraparenchymal hemorrhage. Then systemic inflammation, vasculitis. It will produce Kawasaki-like syndrome. You know that Kawasaki-like syndrome can sometimes have CNS, especially this syndrome is seen in children. Then another manifestation is hypoxia and metabolic problems, which is induced by the virus. It will produce anoxic encephalopathy and related problems. Then I have already mentioned that direct CNS involvement, viral encephalitis, meningitis, and myelitis. And unlike any other organ, neurology will be affected even after the virus has subsided, post-infectious immune-mediated problem. ADAM, that means acute disseminated encephalomyelitis. It is a problem which affects the CNS. Then ANC is acute necrotizing encephalitis in children. This is seen in children. You will see that the brainstem and the thalamus showing a lot of hemorrhagic encephalitis. This is a post-infectious manifestation in children. And GBS. Incidentally, I shall tell you one factor. Till now, Calicut Medical College has not recorded a GBS after COVID. We were surprised because after every outbreak of viral illness, GBS, there will be an immediate increase in the number of GBS. But we are not seeing any increase in GBS during this COVID period. Actually, the number of GBS and these publications, ADAM and other things, has come down dramatically. Previously, we used to get approximately 60, 65, 70 cases of GBS from March 15 to August 15. I think this year, it is less than 10, probably less than 5. Probably this is because of the sanitation and the masking. Other viral infections and gastrointestinal infections are very less, producing a positive effect for the neurologist, for the neurological illness. And finally, muscle. Neuropathy and myopathy can affect, can involve by the COVID. And remember that, don't think that this is the only manifestations, neurological manifestations. We are at the beginning. Forgive me, I think it is the beginning of COVID. The real problem are all going to come in the subsequent months. We may see more and more unusual cases like this. You see this case, it is now admitted in our ward. Patient was admitted with acute paraplegia. He had a COVID in 2 months, 1.5 months back. And after months, he developed acute paraplegia, human paraplegia, and a numbness with a level in the thoracic spine. His MRI was taken. You see these 2 arrows. What we observed, the whole sequence were not shown here. What we see is his pyramidal tract is bilaterally, symmetrically involved from corona radiata down to the spinal cord, lower dorsal spine, pyramidal tract. And you can see that this is the posterior column, which is involved in the cervical area. This is the cervical MRI, which showed dorsal involvement and bilateral pyramidal tract involvement. And these lesions in the brain, the pyramidal tract is involved in a perpendicular longitudinal fashion from the corona radiata down to the brainstem, medulla, and the spinal cord, which is diffusion restricted. Right. It's just like a B12 column and the lateral column selectively involved. Selective involvement of the column we investigated. All the causes for such diseases like paraneoplastic, autoimmune, B12 and all, copper, nothing is positive. And I feel that this is likely to be related to COVID encephalopathy, encephalomyelitis. So, like this, we are going to see cases like this. With this, I will hand over the talk to Dr. Shaji for more details.
Thank you, James, for the lucid presentation. Once you understand the disease, it becomes extremely simple, as what James has presented. A wonderful presentation by James. I thank you. The questions will be taken at the end of the session. I invite Dr. Shaji for the presentation. He is a professor and head of the Department of Neurology at Alappuzha Medical College. He did his DM from the prestigious NIMHANS, Bangalore. And I invite him for the talk. I ask him to share his screen. Over to you, Shaji.
Respected Vice Chancellor, Pro Vice Chancellor, Sir, Raj Mohan Sir, Suma Madam, James Sir. First of all, I am expressing my gratitude for giving an opportunity to present this topic in this webinar. James Sir already discussed everything, especially with regard to detailed pathogenesis. So my duty is very simple, going only on the clinical aspect. Some small slide. Why we are worried about COVID infection? As we know, it is highly infectious and contagious. It has got a high mortality in those people having above the age of 60 years and those having associated comorbidity like hypertension, diabetes, respiratory disease, kidney disease, and malignancies. And it has got some different pathogenesis and varied presentation. So far, there is no effective treatment or vaccine. It is like an octopus which is catching its prey from all the sides. The COVID virus is catching as a pandemic all over the world without any difference in economic or social aspect. The detailed pathogens is already described by James Sir. So it is mainly three pathological mechanisms as direct invasion of CNS by virus, immune-mediated injury, hypoxic and metabolic changes. As you know, Sir is already described, there is a direct injury through the olfactory bulb and olfactory system, and bipolar cells, it affects the olfactory bulb. That is the one of the cause for anosmia. Then second mechanism is there's a hematogenous spread. Then immune-mediated mechanisms mainly like what is happening other immune-mediated disease like multiple sclerosis. The antibody is going to attack myelin basic protein of myelin sheath. As you know, this is the normal neuron and myelin sheath. This is the myelin basic protein is destroyed and there is a demyelination. So this is the immune mediated damage what is going to happen in the central nervous system. Then the third mechanism is occlusion of vessels. It can be either due to the vessel wall inflammation itself or due to the prothrombotic state due to the infection which will produce the occlusion of the vessels. These are the three pathologies will lead to the neurological complications. We should remember there are certain very common clinical presentation of COVID. Of this, most common is headache. This headache is, there are two types of headache. One is the headache induced by the primary infection of the COVID. That is, it is a systemic infection. Systemic infection will produce headache as a part of systemic infection. That is constitute only 8.9%. The second type of headache is more common. That is personal protections equipment induced headache. That is come around 81%. So there's a detailed study which shows that 81% of health workers is having PPE induced headache. The second most common peripheral nervous system manifestation is anosmia. That is we already discussed, because loss of smell is due to the direct infection of the virus on the olfactory tract and bulb, which is appears to be reversible. The anosmia is reversible over a period of 4 weeks. The reason for reversibility is that the neurons is mainly affecting the glial cells rather than primarily on the neurons. So more insult is on glial cells. So the chance of recovery is more. So literature says that over a period of 2 to 4 weeks, most of the anosmia is reversible. But I don't have any personal experience regarding the anosmia. And most severe complications is stroke, as we discussed, either it is a arterial stroke or venous stroke. This is the headache induced by the virus itself. That is a very simple headache. That is a part of systemic infection. But the most important is this headache, PPE induced headache. Yesterday, one of the doctor from our COVID ward asking me, saying that I am having very severe distress and discomfort and mild to moderate headache after wearing the mask. Sir, what I should do? So this PPE induced headache is seen in 81% of patients. There is a questionnaire given, evaluation done in Wuhan, and shows the incidence and prevalence is about 81%. This is due to the traction effect on the face and neck, where the trigeminal nerve is distributed. So the standard recommendation of this PPE-induced headache is just paracetamol. That is sufficient, and reduce the time of taking the duties or wearing the PPE, personal protection equipment. That is the trend. So most common headache is due to PPE-induced headache. Then second thing is, as most common peripheral clinical manifestation is anosmia due to the olfactory system involvement, that is olfactory bulb involvement. Then second complication what we are usually encountered is stroke. It can be arterial stroke because COVID produces a procoagulant state. So the patient can get arterial stroke or venous stroke. Regarding the arterial stroke, what type of treatment we should prefer? That is still in dilemma, or there's no consensus. The present scientific study shows that you should individualize. Normally, whenever a patient having ischemic stroke, what we'll do if the patient come into the window period, we'll take the patient for thrombolysis. Here, the pathology is different. It can be due to primary inflammation of the vessel wall, or due to occlusion, or as a part of systemic manifestation. The current consensus is that you individualize the patient. If the patient having more systemic manifestation, better withdraw from thrombolysis and you go for the systemic treatment. If the patient is having dominant, having a ischemic stroke features, and the systemic manifestation is less, or less severe. So this is the one subset of patient you can go for a thrombolysis. So the decision has to be taken by the physician according to the individual patient. That's the point I want to convey. The second thing is venous stroke. Venous stroke can, as we know, it can present as a classical manifestation of stroke plus seizures. So whenever a patient present with stroke plus seizures, one of the immediate differential diagnosis is venous stroke. Here the drug of choice is low molecular weight heparin, where there is no confusion, because as we know, COVID is a procoagulant state where even if there is no venous stroke or arterial stroke, early institution of low molecular weight heparin is very helpful for management of stroke itself. So early anticoagulation venous stroke, or even without venous stroke itself, early initiation of low molecular weight heparin any COVID patient is standard recommendation, which will reduce the mortality and morbidity of the patient. So there is no confusion regarding the venous stroke. This is one of the patients who madam knows this. One week back, this patient is coming from Chertala. It is a containment zone. So he came to the casualty with features suggestive of a lateral medullary syndrome. He present with ataxia, hiccup, palatal difficulty in swallowing, nasal regurgitation. So our casualty, there is a facility for rapid antigen test. Rapid antigen test is done. It was negative. So we admit the patient in stroke unit, and he's a relatively young patient. His age is only 50 years. So we did the thrombolysis this patient. There is a good improvement for this patient. So surprisingly, on third day onward, patient has got intractable hiccup. So we thought that it's a simple hiccup. We have to wait and see and all. But problem is that on fourth day onwards, he has got a fourth day onwards, he has got a diaphragmatic myoclonus and palatal myoclonus. So we reviewed the literature, and there is a two cases from Wuhan, which says that whenever there is a lateral medullary syndrome, the chance of diaphragmatic myoclonus and palatal myoclonus is their patient had such situation. So we are very enthusiastic. We want to record all these things. So we taken a video recording of this, and I want to do a fluoroscopic documentation of this. So I told the cardiology people they want to do a PCR test. So we sent this patient for initial rapid antigen test was negative. So on the 9th day, all these days he was in stroke ICU. 10th day, we sent for the PCR for fluoroscopic examination and documentation as we want to report this case. This came as positive. That is 10-day patient was in our ICU, and all of us had a exposure. And we all of us undergone the test, swab testing and all. Luckily or unluckily, all of us are negative except two PGs. All these PGs, two PGs, one had a exposure at the time of admission, where they are in the casualty, attend the patient, they put the rice tube, they gone along with patient for taking CT, and they did the thrombolysis. They spend more time with the patient. So two of our PGs had become COVID positive after exposure to this patient. Later, he's transferred to COVID ward. That is our experience in stroke. Then regarding the encephalitis, as already told James sir, it is going through the olfactory tract, and it is very close to the limbic system, temporal lobe. So one of the presentations is limbic encephalitis, another presentation is brainstem encephalitis. Whenever the patient having brainstem encephalitis or brainstem stroke, one of the clinical manifestation is intractable hiccup, or they can have a diaphragmatic plus palatal myoclonus. This we got from our experience. So also from after that, after seeing our patient, we went to the literature. It is well described entity from Italy also. So these cases will go for a supportive measures like anti-edema measures and anti-epileptic drugs. This is the encephalitis picture. Then encephalopathy. Encephalitis, there is a primary inflammation. Encephalopathy, there is a dysfunction of the brain without any inflammation. Here, the patient may present with altered sensorium. Patient may be in altered sensorium, stupor or coma. They can present with PRES, that is posterior reversible encephalopathic syndrome, where patient may present with seizures. They can have loss of vision. There may be some changes in the occipital lobe. Another presentation is ADM. Saris already discussed. That is acute demyelinating encephalomyelopathy, or they can present with steroid responsive encephalopathy, like Hashimoto's encephalopathy. The patient will have a presentation of encephalopathy and will have a very good response to steroids. The worst form of encephalopathy reported is hemorrhagic necrotizing encephalopathy. So far, only 2 cases is reported with regard to COVID. One is from Italy and another is from Wuhan. Here, the patient is present with altered sensorium with seizure. You can see the hemorrhage and necrosis of the brain. They did autopsy study for this patient and isolated the virus from the CSF. You can see the hemorrhage with necrosis of the brain. So next presentation is myelopathy. Of course, this is also autoimmune mediated. As James sir said, there is one report case from temper relation with COVID positive. So far there is one case report from Calicut. He present with a transverse myelopathy. Treatment of choice in this case, myelopathy, is high dose steroid. That is methylprednisolone 1 gram OD for 5 days. That is a standard recommendation because it is a immune mediated myelopathy. Regarding anosmia, I already discussed. Again, loss of taste. Loss of taste is again a reversible phenomena. It is due to the increased number of ACE2 receptors in the taste bud. So as we know, wherever there is a ACE2 receptors, the attachment of virus is very high. So the same mechanism is responsible for the loss of taste. And literature says this is also reversible. So far, we don't have any experience with the loss of taste and anosmia. For me, I personally, I don't have any experience whether it's reversible or not. Again, it is literature says it is reversible because there is no primary neuronal damage. So chance of recovery is very high. Then can present with isolated third nerve palsy. Then another common peripheral nerve manifestation is very frequently this GBS case is reported more from Wuhan rather than from Italy or France, any other area. So far, in my knowledge, we don't have any experience with the GBS secondary to COVID. We are planning to conduct a study in a multi-center as directed by the IPSAR, but so far, surprisingly, GBS is not reported. It may or may not come, but it will respond very well to IVIG. That is the Wuhan study says that very good response to our conventional IVIG. So the loss of smell and taste in a patient with COVID. Then peripheral nerve presentation regarding muscle pain and fatigability is one of the common presentation. It will get in 35% of people. Muscle pain, aches and pains and fatigability. For this, patient requires only rest and simple analgesic like paracetamol. Another is rhabdomyolysis. Again, does not require treatment unless the patient have features of renal failure. Muscle pain. Then we should not forget regarding the drug-induced complication COVID. The patient, the hydroxychloroquine can present with, because most of the time, because of the big publicity in media, and all, the people are initially taken lot of HCQs plus azithromycin. So there is a warning from the health sectors regarding the use of HCQs and azithromycin. HCQs are well known to producing the retinopathy. It can produce myositis and can produce myopathy. So we should also be think of drug-induced myopathies. And the important thing is seizures. Seizures is a very common presentation. I'm not put that slide here. Today I saw in pediatric ward one patient, the 4-year-old boy who present with classical febrile seizure. So they taken it as a one-day fever with seizure, taken it as a classical febrile seizure. Because of the fever, the professor of pediatrics asked to send a COVID test. The PCR came as positive today. So seizure is the one of the presentation, but it is not a common presentation. If seizure present, the drug of choice is levetiracetam. So they can present as a complication of brain manifestation or can be present as an isolated febrile seizure. These are the only two cases I have direct experience. One case of febrile seizure, one case of brain stroke. So thank you, sir. Thank you for giving an opportunity to present this topic. Thank you.
Thank you, Shaji, for the very fantastic presentation, for sharing your experience about the COVID infected and other patients. Another thing which we have noted is we are giving a bad deal for non-COVID patients during this pandemic. Non-COVID stroke patients and non-COVID other patients are really suffering because of COVID. So what is your experience, Shaji?
Yes, sir. It is absolutely correct. Because two things are there. One is the screening. Most of the time, patient is afraid of coming to the hospital because our hospital OPs is closed. There is when patient there is lot of media and people are very much afraid to come to the hospital unless there is a very dire emergency. Then that is one is people not coming to the casualty. Second thing is now for last 2 weeks our stroke IC is closed because of this. It is so far not open. Third thing is absolutely as you said, we are showing some delay of thrombolysis because of whether it is a COVID-induced stroke, whether it is vasculitis induced. So always there is a delay whether to thrombolysis or not, unless there is a direct without any other complication. If it is a direct non-containment area, comorbidity, young patient, we are a little bit away from thrombolysing, sir.
There are some questions in the chat box. How late can be the neurological complications after patient turns negative? Can thrombotic complications be prevented by warfarin or NOAC in high-risk patients like myeloproliferative diseases? What about James? Can you
once more repeat the question?
How late can be the neurological complications after the patient turns negative?
That we can tell correctly because probably it is, I have already mentioned that probably it is the CNS and neurological system which will have problems after COVID becoming negative. This is most of them are due to post-infective problems like any other viral illness which may produce a post-infectious demyelinating problem. COVID can also produce a post-infective demyelinating problem. So Guillain-Barré, Adam, and other such post-infectious problem can occur up to 2 months after the virus become negative. I don't know whether thrombotic complications and other things can occur after the systemic manifestations are over. Logically, it is unlikely.
Second question was, can thrombotic complications be prevented with warfarin or NOAC in high-risk patients like myeloproliferative diseases?
That Shaji has already, I think Shaji has already answered that, because if the systemic complications are there, they are prone for thrombotic complications. Suppose a patient is coming with only an anosmia, which is considered as a common manifestations. In such patients, there is no chance of a thrombotic complications. Thrombotic complications comes when there is a systemic manifestations. Systemic manifestations. So in such cases, when there is systemic manifestations, it's a routine that we are all giving them low molecular weight heparin. Naturally, it will prevent thrombotic complications. And when it is the presentation, stroke as the presentation, Shaji has emphasized that fact that should you do thrombolysis or not, it depends on which is the major one. If it is a stroke as the major manifestations and other systemic manifestations are less, go for thrombolysis. Or if the systemic manifestations are more, rather than thrombolysis, go for low molecular weight heparin. Am I clear?
Another question is, what is the pathophysiology of brainstem encephalitis in COVID? I think Shaji has started discussing about that. Pathophysiology of brainstem encephalitis.
That's to Shaji, isn't it? Question is to Shaji.
Shaji, or you can also take it. Probably.
Let Shaji with that part. Shaji.
There is two theories are telling, sir. One, directly invasion, it has got a tropic effect on the, like rabies virus, it has got a direct tropicity to the brainstem. So there the presentation is like hiccup, intractable myoclonus correlated with diaphragm and palatal myoclonus with presentation as a brainstem stroke, or they can go for a like brainstem, classical brainstem encephalitis, like altered sensorium and coma. It's said to be due to the direct invasion of the virus because of the high number of angiotensin converting 2 receptors in the brainstem.
And Dr. Shiju Chako has specifically asked, any role for NOAC in prevention of thrombotic complications?
I don't know, James sir, I can answer, because low molecular weight is a standard recommendation. Other aspect I was not aware. I reviewed literature, but there is no consensus.
Can I say
James sir,
something?
can you?
Suma madam can say.
Yes, ma'am.
Actually, COVID-19 is a disease, or the pathogenesis is mainly, it is a dysregulated immune system. And the thrombosis or the thrombotic events are very common with COVID, not only in the CNS and others also. The patient can go in for a pulmonary embolism, venous thrombosis and all that. So early stage itself, when there is a hypoxia, early stage of hypoxia, it says that there is a involvement of through ACU2 receptors, involvement of the alveolar cells, type 2 pneumocytes and all that. At that stage itself, when you have a happy hypoxia, it is ideal to start the anticoagulant. That is low molecular weight heparin. And in most of the patients, nowadays, in most of the patients, we have to start the patient on anticoagulant, because otherwise, if that is not being taken care of, the patient can go in for respiratory failure as well. So in COVID, I would say that a very commonly used prophylactic drug is anticoagulants and also steroids along with that, to circumvent the hypoxia and going in for a respiratory failure. Because not only that, actually there is a thrombosis and thrombotic events are taking place, which will go to because of the involvement initially of the epithelium of the respiratory system. Then the endothelial barrier is gone. There will be increase in cells there, and can lead on to the venous thromboembolism and also pulmonary embolism. And usually if these patients go in for a pulmonary embolism, that will be even death can happen immediately. So it is being used very in most of the patients are put on low molecular weight heparin from the early stages itself. Maybe sometimes on the third day itself, patient may go in for a hypoxia. There, this is started, but not waiting for the neurological neurological manifestations to develop. So that's a very common drug to be used in COVID.
The related question is low molecular
But,
weight heparin given as prophylaxis? When will be the ideal time to start? Someone can answer that.
because the patients can come with some patients may not be having any symptoms. They are the asymptomatic group, and then asymptomatic, that is classified as a category A. Then there could be mild symptoms like mild rhinitis or headache or nasal block, throat pain, and cough, dry cough, and that there'll be mild symptoms. And the second category is, along with that, there is another comorbidities like probably hypertension, diabetes mellitus, coronary vascular disease. All this, they are classified as category B. Then severe diseases, there will be category C. So in a symptomatic patient, usually they go without any problems, and even now the government is recommending home care for the asymptomatic patient. But the patient coming with symptoms or on the second or third day, even they can develop, suppose the viral load is high, they can develop a hypoxia. And the hypoxia is hypoxia is termed as happy hypoxia because the patient will not have any symptoms. Patient may not be aware that there is a hypoxia developing, and there will not be any symptoms like breathlessness or tightness of chest. None of them may be there, but some patients may complain of breathlessness. So one thing which we have to do, even the patient is under home care, is to monitor the SpO2, because always you have to, in the hospital you monitor it using the pulse oximeter, or at home sometimes you can ask the patient to exert, that is a 6 minutes walk test and all. So there you will be able to identify the hypoxia. So even by 48 hours the patient can go in for hypoxia. So you have to be on the lookout for a happy hypoxia, that is without any symptoms, but the SpO2 is coming down less than 94. So when it is less than 94, immediately you have to start the patient on heparin as well as the enoxaparin. Then you have to, depending upon the situations or X-ray evidence of pneumonia and all that, you will be starting on plasma therapy or antiviral therapy. So definitely low molecular weight heparin has a prophylactic dose in management of COVID.
So what you are suggesting is those patients who have hypoxia,
yeah,
they can be given prophylactic heparin,
yes,
probably low
yeah.
molecular heparin, not asymptomatic patients or with minimal symptoms like anosmia, etc.
But what I said is that even asymptomatic patient can go in for a hypoxia.
But
We have to be, yeah. Whether, sorry?
Whether we can start low molecular weight heparin for patients with anosmia alone.
Anosmia alone, we have not. Only evidence of hypoxia.
Okay.
And one point Shadi was saying that about the anosmia and loss of taste. It is not uncommon at all. We get a lot of patients with anosmia as well as absence of taste. And I will say that a few patients have presented with that complaint itself. This in the early days. Now I think everybody knows about it, and many patients have come with anosmia. Some patients with anosmia and loss of taste both, and usually recovery happens. Even before the patient has become negative and being discharged, in some patients it has disappeared. But for some patients it may remain a little longer period of time. I don't know why, probably because of the difference in viral load. I'm not sure why it is different for different patients, but there are many patients coming with loss of taste and loss of smell.
There are two related questions. Probably it is most appropriate for KUHS administration. One is from Ravindran sir. He says, at present there is not much facility to do clinical research related to COVID, as there are a lot of restrictions from administrators in sharing data. what can be done in this situation? And Dr. Narayanan Pai has asked, any clinical research initiated in Kerala under KUHS related to COVID? So
It has to be answered by the administration, isn't it?
yeah,
I will answer. This has been taken up at the highest level. That is taken up with the Honorable Minister, Secretary, and they have given us green signal. And actually, Dr. Suma is leading a team of researchers. And our former Dean Research, Dr. Harikumaran Nair, is there in the GME office. And green signal has been given. And now we don't have to wait for somebody to give us data. Data is with us. Data is with us. And that can be documented. And whatever help is needed, university is ready to give. And facilities with the available, we are treating with the available facility and document what we are doing. That is more important. We are doing a wonderful work, everybody knows. But then how we did, we don't document. And that's why whatever we are doing, document. If you go through the journals, Lancet journals, most of the thing which they are writing, we are doing same every day, but we are not documenting, and number of cases are increasing so that, as I was saying earlier, all the papers came from Wuhan with 85,000 cases. Kerala has got now 78,000 cases. It's very bad, but Kerala has got 78,000. And as Dr. James was saying, the worst has not come yet. So, so document what you are seeing. So that is a research. Document, and then subsequently for analyzing part, we have got some difficulties. For that, Dr. Rajmohan is with us, and the university will help. You just document, and we will help you in analyzing. And Professor Shaji is here, and so all of us will help. Thank you.
I think Dr. Thomas Ipe is doing research under DME, no? You have 2 or 3 projects. No?
I just wanted the administration to say that.
Thank you. We have a positive note.
So another question is from the Pro Vice Chancellor itself. Are you doing autopsy in COVID-19 deaths? I'm not really sure.
Autopsy is being done whenever it is needed. Suppose it is a road traffic accident and that has found to be positive. It may not be related, but their autopsy, they use the full PPE and get the autopsy done. Autopsy are being done.
But pathological autopsy is not being done.
Not. We are not doing pathological autopsy.
And patients' dead bodies are kept for some time in the mortuary for practical purposes. I think there are no more questions. No more questions in the chat box. And time is running short. I will hand over the session to Rajmohan sir, who has been instrumental in conducting this series of webinars. I thank him and the Vice Chancellor once again, and hand over the session to Rajmohan sir.
Thank you, Dr. Ipe. And I think today was the first day, so we have every right to call this a day. And our most of our faculty who have joined, actually about nearly more than 120 participants were there, and most of our faculty joined, were present throughout. And I think the YouTube linkage will be viewed by many other persons, because most of the doctors are in COVID duty, and they are very busy in ward work and other clinical work. So for them, the university has made a special provision of uploading these in the YouTube. So the YouTube link can be viewed anytime. And actually our purpose is to facilitate research and to update our faculty with the current knowledge. That is our purpose. So we are committed to these two purposes. Of course, the updation, clinical updating will be reflected in the practice and changed behavior, clinical behavior. There will be more aware of the guidelines and the recent management, and that will be reflected. Of course, there was a question about non-oral anticoagulants, no, and so that is a very recent thing. So always our experience is that whenever there is webinar, there will be the recent questions are asked. That is a good thing. That means the participants are also coming prepared. Most of the participants are coming prepared. Many times we had that experience. So the participants are sometimes more learned than the resource persons. That is a good thing. So we want to make everything in a discussion mode, so that it will be an interactive mode. So further web series will be more and more interactive and more enjoyable to the faculty. And I hope that will be a very heated discussions, and whatever our Honorable VC is dreaming now, that come out with the maximum number of papers. I wish that will happen. Thank you all for your participation, and final word to Dr. Mohan Kundumal, who is our Honorable VC.
Thank you, Rajmohan. And we had an excellent start. And I thank Dr. Thomas Hyde, Dr. James Jose, and Dr. Shaji, and also all the participants. Thank you so much. We will meet tomorrow also. Tomorrow we are going to discuss on cardiological problems, and the password and everything will be the same. So thank you. Good night. Namaste.